All right, everyone. It's 2:05, so let's start with our final session in this Digital Health Week. First, thank you everyone for being here today, and welcome to this final day of this Digital Health Week 2021. It has been a lot of fun, and despite the distance, we have had a magnificent time collaborating with our friends at the University of Sydney during this week. Thank you everyone for all the great work. So one of the things that changed in running an all online event is the question of how to welcome you all to country. Normally, we would have an Aboriginal person in the room with us performing a welcome to country or a smoking ceremony. But as you know, Melbourne's restrictions have seen more flux than most other cities, and we weren't sure what things would look like when we were planning this late last year. So we have for you a video smoking ceremony with Wurundjeri woman Kelly Hunter, and it also includes Ian Gulagong, an elder of the Wurundjeri. So let's see that welcome to country. So thank you for such a powerful welcome to country. Now I would like to introduce all of you to Professor Wendy Chapman, the director of the Center for Digital Transformation of Health, who will officially kick off this last day of this Digital Health Week.
Thank you, Daniel. I'd like to welcome everyone here today and acknowledge that we are, as you heard, on the Wurundjeri country, and pay my respects to elders past, present, and emerging. This is the first time that Melbourne has joined the University of Sydney in co-presenting Digital Health Week. I'm very grateful to my counterpart, Heiko Spalek at the University of Sydney, who invited us to participate in this event, and we hope it's the first of many to come. I went to eHealth Sydney last week during Digital Health Week, and it was a fabulous experience. And this is definitely not the same as talking in the corridor, looking at the posters and having dinner with people. But we're glad that we can bring people that weren't able to come or wouldn't be able to come if we were hosting it in person. I want to tell you a little bit about the Center for Digital Transformation of Health. It's an investment made by the University of Melbourne to bring together people from health and computing and information systems, from business and government, with the shared goal of leveraging digital information and innovation to transform healthcare. And as we head down this path, we know that digital technologies hold enormous promise in improving quality of life. There's no question about that. But they also have the potential to create inequity. And we'll work with experts in health ethics and law to avoid entrenching biases in new technology and then limiting access to health for disadvantaged groups and growing the digital divide. So that brings me to the panel discussion you're about to watch. As my colleague Kathleen Gray observed in her education breakout session earlier this week, many of us have come to digital health by accident rather than by a program of study in informatics. And you're coming from the starting point of things that just don't work, things that could be better. And that's a really great place to start. I'm inspired by Nobel Prize winner Jennifer Doudna, who was jointly awarded the 2020 Nobel Prize in Chemistry. Before COVID, she was traveling the world, including a visit to Melbourne, on a mission not so much about the science of CRISPR technology, but to urge researchers and clinicians to grapple with the what-ifs, the dystopian scenarios, and for scientists and regulators to keep a firm grip on how it's used. As digital health practitioners, it's our job to reconcile as best we can the technical aspects of digital health solutions with rigorous work to ensure equity, access, and safety, and to minimize unintended consequences, which surely will come. It's wonderful to have a panel here today that can speak with deep insight on how these questions affect individuals, communities, and the regulatory environment. So without further ado, I'll hand back to Daniel to introduce our guests. Enjoy the panel.
Thank you, Wendy. That's a great introduction to our next panel. And let me share my screen. There we go. So most of you have probably seen the series Black Mirror on Netflix, and if you haven't and you work in digital, you should. It's a British TV series about a dystopian, but not so distant future where technology has morphed the way the world works. I'm especially inclined to think that future might not be so distant, since we already witnessed how some technologies have been able to influence elections, spread misinformation, exacerbate our differences, and exploit extreme visions of the world and discriminate against minorities. So we wanted to take a look at the chance that this might happen in healthcare. In this panel, we will start with 3 introductory presentations to inspire the discussion. Then we will open up the discussion to everyone. Please post your questions in the Q&A section. We have 2 of our colleagues, Ann Borda and Zarina Tompkins, who will be moderating the questions. We have 3 excellent panelists that will give us a brief introduction to the topic and help us set up the tone for the open discussion. I invite you to use our hashtag, Digital Health Week 21, to tweet if you want to live tweet the session. And so we have Jenny as our panelist. We have first Jenny Waycott. She's an associate professor in the School of Computing and Information Systems, working in the interdisciplinary field of human-computer interaction. Her work broadly aims to understand how new technologies can best be designed and deployed to support people's learning, work, and social activities. Luke Burchill. Luke is an adult congenital heart disease specialist at Royal Melbourne Hospital, and also an associate professor at the University of Melbourne. As a proud member of Victoria's Jajawaring and Yorta communities, Luke leads research and is engaged in national conversations surrounding Indigenous governance and data sovereignty in healthcare and health research. And finally, we have Kobi Leins. She's a senior research fellow in digital ethics in the Faculty of Engineering and IT, and a non-resident fellow of the United Nations Institute for Disarmament. Her research focuses on responsible innovation in AI in the life sciences. To get us started, I will tell you a story that made little noise in the 2020 news cycle because of all the pandemic news. This story involves a cloud-based electronic medical record company. They became very popular in the US, giving the financial incentives that were being paid to providers to implement electronic medical records. In 2020, Practice Fusion settled a lawsuit for $145 million after it was revealed that a drug company had paid them $1 million to modify a decision support system to increase the number of long-acting opioids being prescribed. We all think of clinical decision support systems as tools that will enable us to improve healthcare and accelerate the translation of knowledge into practice. But here we can see a very, disturbing example of what can go wrong. The modified decision support system exploited well-known cognitive biases. And in the 5 years it operated, it is estimated that it triggered 230 million alerts, leading to tens of thousands of additional opioid prescriptions, and most of them paid by Medicare. And you can see here on the graph that all that occurred in the middle of the opioid epidemic in the US, which has claimed hundreds of thousands of lives. So after that very dark episode of digital health, which I think would definitely make an episode of Black Mirror, I leave you with our first panelist, Associate Professor Jenny Waycott. Over to you, Jenny. I'll stop sharing.
Thank you, Daniel. I will now share my screen, and just bear with me while I get my slides ready. Can everybody see that?
Yes.
Excellent, thank you. Okay, thank you very much. Thanks for the invitation to be part of this panel. It's going to be a really interesting discussion. So I was given the task of talking about the individual perspective in terms of thinking about when things might go wrong with digital health. So I'm going to present two stories drawn from my own research. So my research looks at how we can design and use technologies for people in later life, especially in aged care settings, and particularly to support social connections and to provide enriching experiences. So I'm going to present two semi-fictional stories that are drawn from that research that I've been doing. So first, I want to tell you about Agnes. Agnes is a lady in her 90s who lives in a small apartment on her own. She's fiercely independent and a self-confessed loner. Until recently, she relied on her cat for companionship, but her cat sadly passed away recently, and Agnes is unable to replace him. Apart from a nephew who checks in with her a few times a year, Agnes has no family nearby, and she's not interested in making new friends. She receives support from an aged care provider that organises a number of services to enable her to live independently at home, so things like shopping, cooking, cleaning, etc. Because of Agnes's isolation, the aged care organisation has identified her as a suitable candidate for a new trial they're conducting in collaboration with a team of university researchers. The trial involves using a robot to provide companionship. The robot is designed to respond to Agnes's mood with sympathetic speech, and it will send a message to the care provider if it detects Agnes is showing signs of inactivity or low mood. So its role is to provide companionship, but also to monitor and report back to the aged care organisation if there are any concerns about Agnes. Reluctantly, Agnes agrees to take part in the trial, and she initially finds the robot quite amusing and thinks it might, after all, fill part of the gap that's been left by the absence of her much-loved cat. But the robot soon becomes intrusive. Agnes is confused by the robot's behaviour. She doesn't understand what she's done to provoke certain responses, such as when it appears to cry. Agnes worries that the robot is sending negative messages to her aged care provider, and she is extremely fearful that this might lead to her being moved into an aged care home. So in the end, the robot causes a lot of anxiety, and Agnes asks to return it. She feels like a failure for not participating with more enthusiasm, and she feels as though she's been unable to demonstrate to her caregivers that she's willing to try new things and learn new things. So now I would like to share a story about Michael. Again, this is drawn from my research, and this is drawn from my current research. Just to provide a bit of background first about Agnes, that was a semi-fictional account. I did meet people very much like Agnes who were wanted to be left alone and didn't want to be connected to other people. We didn't trial a robot, but I did have an encounter with somebody who didn't want to use our photo sharing app that we were trialing to provide new social connections, and was very worried about that being seen as a sign of her not being able to look after herself anymore. So there's that particular story was based on a real encounter I had. The second story is also very much drawn from my research. So my current research is investigating how immersive virtual reality is being used in aged care. So I'm going to tell the story of Michael. Michael is a man in his late 80s who's lived in a residential care facility for 5 years. He moved into aged care when he could no longer get around independently in his home, and he needed help with daily tasks. In the aged care home, Michael is bored and withdrawn. He doesn't like taking part in the social activities that the care home runs. He has no interest in bingo or other group games and activities. In his younger years, Michael travelled a lot and led a really active life. The care staff know that Michael would like to experience more adventure, but they're constrained in what they can offer in the aged care home. One day, they decide to introduce Michael to a new initiative that they're offering in the care home. Following a trend that seems to be taking off in aged care, the home has recently purchased some virtual reality headsets so they can offer virtual travel as part of their activities program. So wearing the VR headset, a person is fully immersed in a realistic 3D virtual world. So it's a way for people to travel and experience new things when they can't leave the physical environment that they're in, which is one of the reasons this technology has become quite appealing for aged care homes. So the staff decide to try it out with Michael, and you can see here, this is a quote from staff members that I spoke to who had been using virtual reality with their residents. So using the VR headset, Michael was able to go on a virtual African safari, which he loved. Not only did he seem to enjoy the activity, but it also resurfaced forgotten memories. He remembered visiting Africa in his younger years, and he shared this experience with the staff. Although Michael had lived in the home for 5 years, it wasn't until this particular experience that they learned about this holiday travel experience that he'd had. They immediately put this on his care plan for future reminiscence work. So that's the positive side. But being fully immersed is not always, doesn't always provide this sense of enrichment and wonder at exploring the world. It can also be quite frightening. In a later VR session, when exploring the Grand Canyon, Michael suddenly decided he didn't want to do it anymore. He panicked, took the headset off, and said he'd had enough. He didn't want to say what had happened, but later, the staff member discovered that Michael had had a panic attack after navigating to the edge of a cliff and experiencing the sensation of being up high in this realistic and fully immersive 3D virtual world. So again, this story is semi-fictionalized, but it is clearly drawn from my research, and I've used some quotes here from the staff members I spoke to highlight, that these new technologies can provide benefits, but at the same time they can also introduce difficult challenges. Something immersive virtual reality, for example, it is going to be frightening for some people, and we have to be so careful when we're using something like this in an environment like residential aged care. So I want to just end with some questions that this research raises for me, which is, how can we ensure technologies are designed and deployed so that they do achieve these promised social and wellbeing benefits without also creating a burden or being experienced as disempowering, or in the case of the virtual reality, frightening? So that's my provocation. I'm going to end there, but thank you very much.
Thank you, Jenny. That was great, and I think it a great inspiration to our conversation later. Let's pass it on to you, Luke.
Sure. Thank you, Daniel, and thank you for the team for inviting me to this space today. I'm just going to get my slides up here. Hopefully you can see these. So my name is Luke Burchill. I'm an associate professor here at the University of Melbourne, and I lead the Cardiovascular Health Equity Research Group. I'm also a cardiologist at Royal Melbourne Hospital. Already at age 46, I have outlived many Aboriginal men and women who have already died from cardiovascular disease, the leading cause of death and one of the leading contributors to the health gap for Aboriginal Australians. My research is focused on addressing these cardiovascular health inequities. It includes a nationally funded NHMRC clinical trial of wearable monitors for improved diabetes surveillance and management, and involves a number of Aboriginal Torres Strait Islander communities around Australia, including my own, which is the Yorta Yorta mob in Mooroopna, Victoria. Oh, I've got something here, sorry. And a data linkage project in which GP and clinic data is being used to understand how Victorian Aboriginal people access and navigate the mainstream healthcare system. In addition to this Indigenous health research, I have two mainstream research projects. One is called A Full Life. It's a partnership with adults who are living with congenital heart disease, in which we are co-designing new frameworks and formats for patients to share their health and life experiences And more recently, in response to the coronavirus pandemic, I led a collaboration called Royal Melbourne Hive, which is a mental health app for healthcare workers impacted by COVID. So as you can see, I'm doing quite a bit of research in this space, in the digital health space. And I say that I walk these two roads. And as an Aboriginal man, I grapple with the double-edged sword of digital health and the potential risks, as well as the potential promise that it holds for my community. I observed two recurring themes that shape not only the dialogue surrounding Indigenous health research, but broader community perceptions of Aboriginal and Torres Strait Islander people. And I'll just discuss these with you today. The first is terra nullius, the legal doctrine that Australia was unoccupied, or literally no man's land. And just as Aboriginal people are absent in depictions of Captain Arthur Phillip's landing on January 26, 1788, so too are Aboriginal people largely absent in Aboriginal health data sets. And so this theme of terra nullius continues in our digital data sets today. And certainly in research that my group is undertaking at the University of Melbourne, we see this in vastly underrepresented numbers of Victorian Aboriginal people accessing mainstream healthcare services. The second major theme is that of a deficit data problematic people paradigm. It's a bit of a mouthful, but this has been described by Aboriginal sociologist and professor Maggie Walter. She entered into Google Indigenous statistics, and the most common things that she found can be summarised as these 5 Ds. They're the 5 Ds of Indigenous Australian data: disparity, difference, deprivation, disadvantage, and dysfunction. And so in the absence of any alternative narrative, Indigenous people are reduced to statistically informed, often pejorative, racially driven stereotypes. So how do these insights inform a broader discussion about how we define community in this discussion we're having today, but also in and across the spaces that we work? For Aboriginal people, community is really, for us, defined by our country. It's the land of which we are the traditional custodians. And from people comes place, and from place comes people, and with people, community. So our identity and values are really defined by these things. And this is in stark contrast to digital communities, which are a modern invention, and they are defined not by connection to land or country, but increasingly by what is consumed, the data we use, the things we buy, the apps we subscribe to. So these digital identities are based upon who we are as consumers, not who we are as people, and certainly not who we are as communities. So my question is, has the digital revolution already delivered us to the dystopian societies described in George Orwell's 1984 and Aldous Huxley's Brave New World? And central to both of these novels is the fear of losing individual, not only control, but identity, or losing one's identity on one's own terms. So my provocation is really to leave with this question: why is an Indigenous health lens important for the conversations we are having here today? Why is an Indigenous lens important for the question of community in digital health? I submit that it's important because we as a peoples understand too well the value of sovereignty. Sovereignty not only over our country, but also over how we are defined and how we identify as Aboriginal peoples and communities. Thank you.
Thank you, Luke. Thank you, Luke. That was great. Over to you, Kobi.
You're on mute, Kobi.
I just did that thing. Thank you, Luke, so much. Thanks, Daniel, for the introduction. Thanks, Luke and Jenny, for such provocative presentations. I feel really honoured to be here. This is such a big topic, and I have the luxury of doing the zoom out version. So we've had the narratives from Jenny about the individuals, the fascinating presentation by Luke about communities. And what I want to do is draw our attention out just a little bit more. So if we think about more of a global perspective, which is where I come from. My background is working with communities on biological and chemical weapons and working in international organisations such as the UN. So my perspective is quite different. I'm trained as a lawyer, but I've come to AI in the last few years because I was working on issues in my PhD that made me realise that these are questions that they're just not going to go away. I'm going to start my actual presentation by first of all just referring to the slide behind me, which would segue hopefully from Luke's presentation, to say that we in Australia, which many people don't even know, have one of the oldest engineering projects in the world. Behind me is a photo of the Brewarrina fish traps. And these traps were a very complicated system that we used to capture, store and preserve fish for food. The different pools had different temperatures, and to this day, 40,000 years later, this structure still exists. And I think one of the things that we do have to mention in any talk right now is that we need to think about what we're building and what the environmental impact is. So global issues include thinking about when we're building technological solutions, will they be as gentle on the environment or as sustaining and as long lasting as anything that any of the Indigenous peoples here in Australia have built? And I encourage you, if you get a chance, to see any of these structures, some of the engineering feats by Indigenous peoples in Australia, including the ovens and many others, are some of the most amazing in the world. So one of the things that's often overlooked in this field, in any field that's grappling to use technology, and there are many of them, is this idea that technology is not neutral. And what often happens in these kinds of presentations is that people fall into the dystopian, which we are here as a whole panel to represent, or alternatively the utopian, technology will solve all our problems. And I always jokingly say that, computing is not binary, haha, because it is ones and zeros. It's really not that simple. Every single system that we build, every single tool that we use, and this goes from the beginning of time throughout history, is placed in a socio-technological context. So Langdon Winner is a fantastic place to start. He talks about the different structures that we build and how these affect the power and or are built out of certain philosophies and certain ways of thinking that we have. And an example he gives is in New York, where the overpasses were built to deliberately keep out the buses. So the overpasses were built quite low because the buses were what brought in people from the outer suburbs, who are often people of colour, who they didn't want coming into New York. This is a really good example, and it's a really simplistic one, because in this particular instance, you could see the bridges, you could see the buses, you could see that they wouldn't fit, and it was quite clear what was happening. What's happening now is that, particularly when we're talking about deep networks or neural networks or any sort of self-learning algorithm, is that it's not possible. It is extremely challenging and arguably not possible, although many are working on explainable AI, to ask questions in the same way that we could before. The levels of expertise that are necessary are so high to interrogate these systems. So to Daniel's point, the case that was nudged slightly to make greater recommendations for drugs took a long time to be discovered, and the litigation in that case will exist for years. So the other issue is that the speed and the scale at which these systems operate make them particular. So an error or an oversight, not even necessarily an active error, but an oversight, may result in such a scale of deaths, as Daniel has indicated, or of isolation or of impact, as Luke has discussed, that those kind of errors really need to be, or that those kind of situations really need to be minimised. We've seen such a huge shift over the last year, and many questions are coming to mind. From a global perspective, there are multiple bodies that are currently trying to put together governance over and around AI. Just this week, KPMG published a report in Australia that litmus test what the tolerance was or the desire was, and the conclusion was resounding that people in Australia want AI to be regulated. A lot of people don't understand it. They're skeptical of it, and they really want to have safeguards around AI. Now, what does that actually mean? I spent 2 hours this morning on an International Standards Organisation meeting, one of many, discussing the definition of AI. This sounds absurd, but there is such a complexity and such a broad church of understanding of what AI actually is and what digital technologies actually are, that even defining them before you get to the regulation of them is something that's incredibly challenging. In terms of what we're doing now, one of the most interesting examples during COVID that I've heard of is the collection, and you would have heard of this as well, finding COVID remnants in the sewage and other sources, which begs the question, what kind of data are we collecting about people? Not just the tracking of data through movements on Facebook, which is some of what we're doing, but also what kind of de-identification of the DNA is there? Is it ever truly de-identifiable? And where is that data being stored? What else is it being connected to? The data questions are obvious, pressing and pertinent, and often overlooked. The data in particular is relevant when we think about the fact that the genomic data project, which took nearly 13 years to complete, can now be done in approximately a day with current computing abilities. So the ability to map and to track and to identify individuals, or to map and track and link to other data, is really a pressing issue. That was 3.3 billion base pairs, by the way, which apparently can be done today at much lower cost and within a day. The other thing I wanted to finish with, and my provocation, is that what I see in a lot of, particularly in the health areas and in life sciences, is an understandable rush, and we've seen that through the discovery and the upside, the discovery and the incredibly fast creation of the vaccines, is often a rush to create an outcome or a solution without necessarily contemplating what the problem was. In COVID, the case of COVID is quite clear, but in many of these situations, I think we are sometimes grasping for technology, and I know this is going to be a provocative statement, without necessarily fundamentally asking what the problem is that we're trying to solve. And Sheila Yazanoff talked about this in Science and Technology Studies. She refers to them as socio-technical imaginaries. So often when we're building a thing to fix a thing, what we're doing is masking another thing that's actually a bigger problem, that's a societal problem. So if you think of it, for example, if we're building numerous apps that are going to improve mental health, perhaps the problem is not so much people's mental health as the fact that we have such high rates of unemployment and job insecurity and their broader, lack of healthcare in certain countries. Perhaps those issues are too hard to grapple, and what we're trying to do is to find quicker solutions. So I suppose my provocation that I would like to leave you with from a governance perspective is, well, firstly, if you're building these systems, who's in the room to help build them and help you think about what the risks are to you building and using these systems, not just as you build them, but also as you roll them out and on an ongoing basis. But secondly, what sort of limits do you think that you need, or do you worry about in your work, or do you think about generally in terms of limits to the use of these tools? Luke and Jenny have already flagged some of the risks, but I think there are much broader risks, even around now, for example, how are we representing, or how are we able to talk about public health risks? So there's a social media aspect as well. So this is an incredibly broad topic, and I really look forward to the conversation. Thanks again.
Thank you, Kobi. That was great. Great provocation, especially the last question. I would invite our panelists now to turn on their cameras so we can have a rich discussion about all these different scenarios. And I invite the audience. We have 70 people attending right now to please use the Q&A section. Anne and Zarina will be monitoring those questions and sending them out to us so we can address them properly. So I would like to ask Kobi's initial final question was what's the underlying problem that we're trying to solve with technology, and she addressed or mentioned the specific issue of mental health, and Luke has been working on precisely that, creating and co-designing an app for clinicians, tackle this problem of mental health. And that also collides with this additional phenomenon that we have seen with the deployment of electronic health records. They were deployed to make healthcare better, to streamline knowledge translation, but 20 years down the road, we found out that electronic medical records were a key ingredient in clinician burnout. So how can we, I don't know, this just blows my brains to just think about how all these technologies are interacting. So what are your thoughts, Luke, around this?
Thanks, Daniel and Kobi, for the provocation. I think that this is a really good place to start. Yeah, as I said, I bring an Indigenous perspective to this, but even so, here I am deploying a mental health app among my colleagues at Royal Melbourne Hospital. And, I think that sometimes we have this action bias. We see a threat, we want to do something, we deploy. And I can see there's a comment here from Carissa Bonner, who's saying that, yes, there's a lot of enthusiasm for new tech ideas without a clear idea of the problem to address and whose behaviour needs to change. Certainly in our project, we were undertaking a rapid deployment and delivery process, but we were doing a review of the literature at the time. And not surprisingly, we found that just interventions that dealt with safety issues, access to PPE, having management that actually listened and responded to healthcare workers, guess what? Had a major influence on mental health. So, this is a good example of delivering mindfulness meditation to people that were scared because of observed and real high COVID transmission within hospitals. Is not paying attention to the real problem. And I really love this socio-technical imaginaries, Kobi. So I'll be using that in my work. So I'll stop there. There's more I could say, but I want to share the love and hear from Kobi and Jenny as well.
Are you happy for me to jump in?
Yeah, jump in, please.
Okay, great. One thing I was going to say is that in terms of managing these risks, and Daniel, you mentioned the EMRs being a component in burnout among medical staff, which was just went right against the intention. So I think we get caught up in the design and the idea of co-designing, which is important, and involving people in the design process, which is important. But I think I believe that design continues in use, and that as we start using new technologies, we find that they new ways of working come about that we didn't know or didn't anticipate during that design phase. And I think it's really important that that we continue that relationship throughout the process, not just before we introduce the technology, but beyond as well. And I think understanding where things have unintended consequences means really paying attention to what happens when the technology is out there in the real world.
Thank you, Jenny. Kobi?
Couldn't agree more. Absolutely. Don't make it a check-a-box exercise. It's not a one-off. I've done that. I've had insert minoritized groups here in the room to tell me what to do. It's all fine. It requires deeper thinking. So to the project, to the Human Genomic Project, to which I referred, for example, all of that genomic data is European data. So much of the research and the work that we're doing is based on white Europeans, which is problematic. So you've got to think about your hardware, you've got to think about your software, you've got to think about your data, and then you need to think about all of those continuously. I would add to that as well, one of the aspects which I think is really key, and one of our colleagues does a lot of work on this, Sulette Dreyfus, is this idea of whistleblowing that she looks at in another context has immense usefulness in this particular area. And Toyota is a really good example. Toyota, the car company, actually introduced this in their car production line. So if someone saw a problem, they could basically put their hand up and go, hey, this needs to stop. And I think with technical systems that move as quickly as we're seeing now, there is going to need to be, as a risk management tool, that's going to be needed for systems to actually circuit break what can otherwise be incredibly long-term and devastating impact.
Thank you, Kobi. I also wanted to touch base on the issue of sovereignty that Luke mentioned. When you think about this, continuous design and listening to users over time, it sounds great, but when you're using a platform that was developed, hundreds of miles or thousands of miles away, and there's not much you can do to modify, your interface, or at least convey your preoccupations with how it's working. I can see that as happening with clinicians using their EMRs, and they can't influence how they operate. And if you want to influence, then they bill you many thousands of dollars to make any slight modification. So we have this tension between the platforms telling us there's no need to regulate us. The final user is the responsible person in the room to make those decisions, but on the other hand, there's no way to make that happen. How do you see those things happening in life, and maybe and connecting it to real health issues? The TGA recently published a set of rules deciding which digital and software as a medical device were going to be excluded from their regulation, and decision support tools where there's a clinician at the end are explicitly excluded. And we contrast that to the case that I just gave you. So again, we have this environment where we're saying, the final user has a lot of responsibility on how these things are used, which is what the TGA seems to be, the path of the TGA seems to be taking. But on the other hand, there's no real pathways for that to actually happen. How do we grapple with those tensions, if it's possible?
For me, I'll be interested in Kobi and sort of the legal response. I think that this does get there. I'm talking about governance, and it's also about really agreeing on what we're talking about when we say these terms community and we say the term co-design. So for me, and the project that we did, co-design takes time, and co-design alone doesn't actually mean a lot. I see a lot of research that uses co-design principles, and it really is just a fancy way of saying they've sat down and talked with the envisaged end user. That's not how our project worked because of the way that we approach it. So for me, it's about giving people agency and the community agency and power. So how do you actually address the power dynamics that naturally emerge when there is a researcher or a development team wanting to help through the delivery of these new technologies, but a community that often is disempowered through the process because there aren't these ongoing feedback loops. And in fact, there isn't an ability to reset the mainframe if in fact it's discovered that the intention is not realized. So you mentioned EMRs, and if we had have been able to provide the adequate feedback from clinicians, I don't know if we would still have EMRs, because I think there was enough signals from the end users that this was actually damaging to health. But we did not have feedback loops, we did not have governance structures that worked to empower the voice of the end user. I think that's the fundamental problem.
Thank you, Luke. Kobi, what are your thoughts?
This is such a broad field. I'm trying to think about where to start, and I'm looking at that question as well. How do we balance wanting to help versus doing harm? I think from a governance perspective, I mean, it's really interesting you mentioned about the TGA ruling out certain devices. From a legal point of view, there are simple answers to these questions in a way, and I'm going to just hold that thought or this imaginary for a moment, which is that in the automotive industry, just hearing you talk, Daniel, made me think about automation within weaponry systems, which is something that I was part of my PhD work, is something that has a debate that's gone on for years and years and years. Is there a human in the loop? Is there a meaningful human interaction on the loop? Is there a meaningful human interaction that can stop the machine? Like the language has just become more and more complex, and and diluted, whereas in the automotive industry, there's an ISO standard that has 5 levels of automation, and it's quite clear what each level's from, basic algorithms through to completely autonomous. There's a wide range, and they've basically said in each of these 5 categories, these are the level of regulation we need. And I'm going to be provocative again and say that we could actually use a similar framework for digital devices. So it's not about having a human on the loop, because by the time a human gets something that's been pre-digested by AI, it's based on data that you can't introspect, systems you can't see or necessarily understand, with assumptions built into the algorithms you can't question. It's too late. It's not enough to just have a human at some point along the system. There actually need to be interrogations, as Jenny said, sort of continuously and along the way. And I think that sort of model of having different governance levels for different levels of autonomy is fundamental to the safety of medical devices. And it's going to take another couple of cases, unfortunately, until companies are going to say, boards and directors are going to say, there's such a great risk to my company here of this kind of thing happening and litigation coming. And that's when you'll start seeing the regulation roll in. And I think we're just on the cusp of that, quite frankly, which this KPMG report also indicates, to answer Luke's question.
Thank you, Kobi. So we have a question from the audience, and I think Jenny is the best person to answer this one. Is, in digital health, we're trying to strike a balance between responding in a timely way, and we have seen this, during the pandemic, but also doing our due diligence and doing it right. So what are your thoughts on ways that we can ensure to be responsive, but in a thoughtful way?
I think it's hard to get the timing right. I think there's a quote that I remember hearing previously is that technology runs and research walks, or something along those lines. So the industry is in a race, and research is a lot more slower pace. So when we're doing our evaluations, getting that feedback back so that it can inform further to improve the technologies that are being used is really difficult. So I think there's bigger issues that we need to kind of grapple with. I just want to put in a plug for the kind of research that I do. So I'm a qualitative researcher, and I sometimes say I collect stories. I collect stories about people's experiences with technology. And so you saw some of those parts of those stories in my talk earlier. And I think those stories are really important because they give us information that we can't capture through the kind of measures and other kinds of evaluations. And so I think we need that balance between, testing whether something works in terms of having the impact that we're aiming for, and really getting to grips with what the experience is like for the person using the technology, managing their health, going about their day-to-day life with this system, supporting or potentially detracting from their goals. So I think collecting people's stories and feeding them back into having some sort of loop that enables that to go into the design process is really important.
Thank you, Jenny. There's another comment here from Kate in the audience. She says, agree with so many of these points. We are 10 years behind other technology-led industries in prioritizing usability, and I see a real gap in having access to specific guidelines, heuristics, or standards in use to force vendors to take this work on in a serious way. Working as design, in quotes, is a microaggression, she says. And I remember in the past I worked deploying an electronic medical record in an academic hospital back in Chile, and at some point we saw in the ED, and the system, I must admit, it was, it had lots of problems in how it worked. At some point we didn't have a mechanism to collect people's stories. And once we started seeing, the people have relabeled the icons on your desktops. So, let's say the name of the EMR, and then, some, very, words I can't repeat, here live as, as adjectives that were added to the names of those in those icons. So when we started seeing those popping up, we then learned that they were the orthopedic surgeons that they were relabeling the icons, and then we did the survey, and it was just mind-blowing, the amount of negativity that had been accumulating across users, and that really got us thinking that the product needed some deep changes that we weren't able to implement, because again, we didn't have enough agency to make those changes. It's like asking Microsoft to change the position of the start button. It just won't happen. Kate is also another comment. She says, we have a lag with knowledge translation and clinical practice. We're placed with research evidence, research focus, and digital health. How do we bring vendors along with us? I don't know if you have, Luke, you have experienced this deployment of an EMR recently in your workplace. How do you see the whole deal of using EMRs as a knowledge translation device, and how do we engage vendors in this process?
With great difficulty is my answer, because I tried to do that. And I think what's interesting is that how quickly the hospital and healthcare networks become agents of the EMR companies. That was at least my experience. So we tried to recommend a pre and post evaluation of healthcare worker wellbeing before and after Epic was introduced here. And it was blocked at many levels because people really didn't want to know the reality of how it might impact not just our workflow, but our enjoyment of work and our ability to connect with our patients. I proposed it because I've been working with these EMRs while overseas in North America for the last 9 or 10 years. And I'd seen the impact that it has on clinicians' wellbeing. But many people had already been flown for training overseas, and they had the handbooks on how to implement the EMR, and addressing that culture. I think, again, for me, it comes back to how do you hear the voices of the community? And I can see there's one question here, sorry, that I've been asked to address, and it came from Caroline. Thank you, Caroline. It's about having the right voices heard at the right time. I guess I've just made a comment on that, but I wanted to pick up a little bit on what Jenny said and sort of draw it out a little bit more. My research also is very interested in giving people a safe space for their voices to be heard. But where I'm at the moment with that is also understanding that we have still ethical sort of responsibilities around why we're collecting those stories. And I think, at least in the Indigenous space, sometimes our stories are still used in tokenistic ways, or I call it sort of this cultural voyeurism. And so again, like before we create an early space for people to raise their voice, those voices are still only going to be effective if we've paid attention to who's in the room, what are the power dynamics at play, and how do elite respond to non-elite voices? And what's the response when those non-elite voices have needs that are at odds with those that have been in power and privilege for extended periods of time?
Can I just jump in, Daniel?
Please do.
I've been grappling with the same questions in my work, and I think for those who followed the firing of Timnit Gebru at Google, they're asking a lot of the same questions. There's some interesting work around the fact that you can't change the culture of an organisation as one individual, and particularly not if you're the minoritised individual. I use the word minoritized really consciously. It's a word that Timnit coined because it's not people who are necessarily minorities, it's people who are made minorities or are forced to be minorities. So having them in the room is one thing, but having them have secure tenure or secure jobs or feeling comfortable and safe enough to speak is another thing. And I think that's a really, really important point, Luke. So you could have, every possible group from disability, aged, Indigenous through to, sexuality preferences. But if those people don't feel safe enough in their work to speak out or to express concerns, that's a problem. And the deeper problem with that, which I'm looking at in some of my work, is that more and more people are starting to write about these blind spots in work itself, in research itself. So my favorite example is birdsong. So men used to, it's really inane, but they researched whether birds sang, and the men said all the birds sing and they're all male birds that sing. And then women started researching it and they went, but there are female birds that are singing. This is a fairly harmless example, and yet the same thing is happening in all of our areas of research. As soon as women come into it, the research changes. As soon as you get different gender identities, the research changes. As soon as you have people with disabilities, which Jenny can speak to far better than I can, you have a completely different perspective on the research when you have people in the room who've had lived experience and ask the questions. And the challenge with that is that if you make that a requirement for academic institutions and not for industry, guess who's going to pull ahead economically? Because this stuff is slow and it takes time. Just like it took time to build the Indigenous structures, just like it took time and it took money to build anything that's sustainable, that lasts a long period, we have to rethink how we're working. Because moving fast and breaking things is breaking people, and it's breaking communities, and it's breaking our society, and we can't do it anymore. We have to change the way we work, and that has to apply to both industry and to technology, and I think that to academia, and I think that's enough of a provocation for one session now.
Wow, that's great. Here's another comment that we have from Audrey in the audience. She says, perhaps people who calculate risk versus taking risk need to input independently into our evaluation of models being used for AI for medicine or health services. Should we be looking at models that regulate other industries, such as banks, now that disaster has struck for them? For example, bank loans that created the 2008 financial crisis. Is there any industry that we can look at, regarding this regulation? Because again, we're seeing, if we look at banks, and what happened, last week, stocks going crazy because, some person, smart person figured out how to exploit the, investing gambling that was happening. And I don't know, is there any industry that we can look into to inspire? Or what do you think, Kobi?
Yes, but I'm trying not to monologue and dominate. Funny you should ask that. I have a paper that's in the works. Nuclear physicists had the nuclear bomb. Chemists had chemical weapons. Biologists also had to deal with this. We have a biological weapons convention. There's a moment of reckoning that I think we are facing with computer science, that in the computer science communities, we need to grapple with misuse, dual use, and hostile use. And I think that's going to need to happen fairly quickly. So to some of the questions before, the ISO standards are currently under negotiation, far too slowly than many would like, but those standards will come in, and any company using AI who wants to be certified will need to have those standards. IEEE will be doing the same. But in short, I think we really need to, there's a lot of moving parts, but there will be responses.
Thank you, Kobi. Brian Chapman here has an interesting point. Says it's a fundamental mathematical principle that global optimization requires acceptance of error. Unwillingness to accept error limits us to only achieving local improvements, and that will not achieve global or a global optimum. Assuming that healthcare is not operating in a globally optimal manner, arriving at a substantially improved operating point can only be achieved through a process that will induce transient errors. That is, digital health cannot create an optimally transformed healthcare system without making errors along the way. Do healthcare systems have enough tolerance for risk and error to make substantial improvements in how it operates? I don't know. I'm gonna try to comment on that. I think, of course, research is a risky business, risky in terms of, you don't know what's the outcome going to be. And I think in healthcare, we don't have the tolerance for that kind of errors. And I think that's to some degree, that's right. Because again, as Kobi says, if you move fast, and you're going to break things and you're going to break people. But on the other hand, I recognize Brian's point. That's what, in medical education, simulation became, an important tool to address those things. For many, I learned to put central catheters on humans. I never used a dummy, and I did, not everything was a success from the very beginning. So, that's how we were taught. Now, thank God people are taught in a better way. I think that at least from our perspective in the Center for Digital Transformation of Health, we think that we need this kind of, risk-tolerant environments where we can use all these different tools that we're generating, synthetic environments, synthetic patient data, to try to understand better how these algorithms, how these systems actually perform before we move them into, real production. So we can move a little bit of that risk out of, the patient community to actually allow for what Brian is describing, allowing this innovation to happen, but on the other hand, protecting, patients and communities from being broken, in the process.
Can I add to that, Daniel?
Absolutely.
I want to something that Kobi said when in her introductory talk about that we often see technology is often discussed in either the dystopian view or it's a solution view. So there's this sense that it's this dichotomy, but actually there's the area in between that I think we really need to understand. And that question raised for me this tension that I have in the work that I do, because I'm looking at what are the benefits, how can these technologies be used to enrich people's lives, to create social connections. And there are some fantastic stories about, so the example of virtual reality that I presented earlier, there are some fantastic stories about it working wonders with people living in aged care and really opening up a new experience for them. But at the same time, there are these really stories of quite considerable risk and potential for harm through the same the same technologies. And I'm wondering, I think if we focus too much on what can go wrong, there's the danger that we won't allow space for those benefits to take place, and for that innovation that Brian is talking about to develop. But of course, we need to make sure that those risks are carefully managed, and so that's the area that I think we need to do a lot of work in.
Thank you, Jenny.
Jenny,
go ahead, Luke.
I'll just sort of pick up on that. I mentioned the concept or the principle of terra nullius and our being absent when Australia was first discovered by European people, and also now in our data sets. So here is another risk. One risk is that we talk about sovereignty and we talk about the risks of digital data to the extent that Aboriginal and Torres Strait Islander people don't engage with data-driven health research or data linkage. Well, the risk is that we don't have health policy based upon evidence. And I can tell you, I sit on the Australian Institute of Health and Welfare Cardiovascular Expert Advisory Group, and Victoria is just blank. It is blank because there's been a decision that the data is not reliable for Victorian Aboriginal people. So you're right. I think that we can't just sort of sit in an echo chamber repeating these concerns about risks. We need to also be able to step forward, lean in, and come up with solutions so that we can manage the risks to use the data for our benefit. I think it does still come back to people being able to have agency in that space, though, because when you say, well, actually, we want to be recognised, or actually, we do want these solutions to be delivered because maybe they will be helpful. Again, how do we track that over time? And my final comment is just this, I'm picking up on the word global. It's sort of going around in my head as I think about Brian's question. And I think that it's almost like this term, you know, systemic racism and again, community. I worry about how diffuse these terms are. And when I think about Royal Melbourne Hospital and being a cardiologist here and the care we're trying to deliver, I think that better quality care and better outcomes could be achieved if we paid more attention to the communities that we are servicing. That is the country that we're on, but also those postcodes that are highly represented in the healthcare services. Where are they represented in the decisions that we make in this healthcare network? That's how we'll start to de-risk. And it can't just involve, say, the outcome after surgery and the outcome after procedures, particularly when we know there's whole groups of people that don't have access to them in the first place. And that's a major risk.
Thank you, Luke. Brian here clarifies that he was talking about global in a mathematical, not a geopolitical sense.
Sorry, Brian, I stand corrected. But that's good. That's good for us, I think, to tease out, because this is what I mean. Let's define the terms so that we know what we're talking about. So that's very helpful. Thank you, Brian.
Absolutely. We are on time, you know, for the end of our discussion panel. I think we could go on forever discussing these topics. I'm extremely excited about the conversation that has emerged here. I would like to, first of all, thank all our panelists, Kobi, Jenny, Luke, for your inspiring cases, for your reflections, and for your overall discussion here. I would also want to thank everyone who participated sending questions through the Q&A. We tried to answer most of them. I know some of them were left unanswered. We'll do our best to get back to you, sending the questions to the corresponding panelists and see if we can you know, find an answer for those questions. But I also invite everyone to join, you know, discussions on Twitter. I know that Kobi and Jenny, they're both on Twitter. I don't know if Luke is in Twitter and I haven't discovered you.
No, I've never engaged with any social media.
That's probably wise. So again, I would like to everyone to, you know, give an applause, you know, virtual applause to all our panelists. I think this was great. So thank you everyone.
Well done, Daniel, and thank you very much. It's an honour to have attended and to be here with you, Jenny and Kobi. I really appreciate it. Thank you.
What Luke just said. Thank you. And
we're not done with our session today, so please don't start jumping off our final session. It's only time to wrap up the panel, but we're still in the final moments of our Digital Health Week 2021. I remind you of this our hashtag that you can use to tweet about these sessions or what's coming now. So again, once again, thanks to our amazing panelists. Again, I'm very excited for the conversation that emerged here. This was an extremely relevant conversation. And as this is the final day of our Digital Health Week, we would like to begin our award session. And let's think of it as our Digital Health Oscar Awards. So, but before I announce the winners, I'll explain a little bit about each of the prizes. So we have one for Emerging Digital Health Researchers Prize. This has been set up to celebrate the talent of higher degree research students in digital health. The presenters were judged on the quality of the research and how engaging the presentation was. There's one prize for each of the 5 sessions that we witnessed during the week. There's an e-poster, People's Choice. The general public voted for who won the prize, and votes were counted up till 9 a.m. this morning. The winner of this prize received almost 1,000 votes. There's an e-poster influencer based on the tweets or retweets or likes using the conference hashtag, and the prize went to the e-poster with the most Twitter engagement. We have the e-poster conference committee choice, and this will be announced after the end of the conference and announced next week to the winners. And we have a commendation award. The Digital Health Week 21 conference committee has introduced a special commendation award to acknowledge the achievements and participation of an attendee during our Digital Health Week 2021. So let's move on to the winners. I hope everyone is seeing my slides. If you're not, please scream at me. So congratulations to the Emerging Digital Health Researchers. Here you can see the list of winners for digital health and disability. We have Jao Carbonati, eHealth Education, Dr. Anthony Sunjaya for mHealth, Sibohan Wong for digital health, digital public health, Lillian Chan, and for digital health tools, data, Anna Fedyukova. So congratulations to you all. We have the e-posters awards for the People's Choice Awards, Samadhi Weerasinghe from Sri Lanka, and the Influence Award for Natasha Lazarevich. Again, big round of applause to them. And the Special Commendation Award goes to Digital Health Innovator, Dennis Senyonwa from the Uganda Martyrs University. And he proposed a use case model application for technology integrating public health interventions with households to mitigate mortality and morbidity to communicable and non-communicable diseases in primary healthcare in Uganda. And we know that Dennis, he was joining our sessions, early in the morning at his time zone. So again, this is our Special Commendation Award for this week. So before we move to our artists, I would like to, again, let you know that all winners will be contacted next week to organize receipt of their prize. And of course, you've already noticed there's a big absence. I think we've all felt this week, and that, webinars don't allow us for a big applause. The sound of one hand clapping doesn't really translate into what we will feel in a big audience. Maybe someone at some point will come up with a digital solution for that, or maybe we should just keep meeting in person. But in the meantime, I would invite you to do a virtual standing ovation to all these awardees of these present prizes during this Digital Health Week. Serena let us know that there's a confetti emoji, there's hands clapping, so please use them all to congratulate our winners this week. And finally, I would like to make a mention of our artists in residence. As you know, we've had our artists in residence attending each day to create 3 artworks inspired by our conference and the ideas that you've shared. Farashet is currently working on a 3rd one, and we'll get a sneak peek on Twitter later today. But on the screen, you can see the latest version of the Keynote and Dystopian Wednesday artworks. After the conference, we will be auctioning the artworks online, and all the funds will be donated to 2 charities, the Go Foundation, which provides scholarships to Indigenous students from kindergarten through university in public and independent schools, to students who live with family and community and country. and also Brain Injury Australia, the peak advocacy and support network in Australia for the over 700,000 people with brain injury and their families and supporters. So again, these pieces have been incredible, and we really appreciated seeing our digital health ideas throughout your eyes and your talented hands. Thank you for your support for our event and showing everyone that you can wear multiple hats to be an incredible researcher, teacher, clinician, and artist, all at the same time. So as we draw to an end, I would like to invite our director, Professor Wendy Chapman, to send us off with the closing remarks for this Digital Health Week. On to you, Wendy.
Daniel. Yeah, thank you for that fascinating session, for the great discussion, the artwork, and the awards. This brings Digital Health Week to an end, but we hope that the conversations that we began here will continue. There are many people to thank today. I'd like to congratulate the University of Sydney Working Group, who was, that group was chaired by Mel Keep, who's tireless and creative and is passing her baton on to Liz Brunner. I'd like to thank Anna Janssen, Nicola Straighton, Ling Zhang, Jessica Orchard, Jacqueline Wells, supported by student ambassadors Catherine Jung, Alex Finlay-Jones, Olivia Lecoq, Nicole Baxter, Ahmed Abid, and our Twitterati, Anna Singleton and Natasha Lazarevich. Also, Milan Vagasia, and they've all done a superb job. In Melbourne, I'd like to thank Daniel Capurro, Ann Borda, Zarina Tompkins, Riva Liederman, Rodrigo Marino, and Kathleen Gray, who all participated. We're sorry to be losing our center's deputy director, Karen Verspoor, who is starting a new chapter in her career as Dean of RMIT University School of Computing Technologies, but looking forward to collaborating with them in the future. And of course, our panelists today, Kobi, Jenny, and Luke. So thank you everyone for being part of something truly special. I want to point your attention, in case you didn't know, that there are workshops affiliated with this, and they start next week and the week after. So the one next week is Data Science for Clinical Applications, and the following week is Design of Clinical Decision Support Systems. Those are they'll be very hands-on, led by experts and professionals who spend a lot of time preparing, and I hope that you'll be able to join those. And with that, we'll see you next year.
Thank you so much, Wendy, and thanks everyone for being here today. It's been a great experience. See you next year.